Hello, my name is Dr. Kelly Roof, and I am a clinical educator here at Precision Analytical. And I just want to welcome you all to the January installment of the Dutch webinar series. In today's session, we're excited to welcome Dr. Jaclyn Smeaton, who will delve into the topic of menopausal hormone replacement therapy. Thank you for joining us to gain valuable insights into a more effective and integrative approach to this topic. Dr. Smeaton is the Chief Medical Officer at Precision Analytical and a naturopathic physician focused on infertility, reproductive, and genitourinary health. In addition to her private practice, Hello Fertility, she is a prolific teacher in the field of reproductive endocrinology and hormones and has trained thousands of clinicians in her treatment methodology. Dr. Smeaton has extensive leadership experience in integrative medicine, including as president of the American Association of Naturopathic Physicians, as an ambassador for the Academy of Integrative Health and Medicine, and a board member of the Integrative Health Policy Consortium. If you're ready to start using Dutch testing in your practice, sign up as a registered provider today. It's really easy. Just click the link we posted in the chat and complete our provider application form. A member of our onboarding team will walk you through the steps to set up an account so you can begin taking advantage of all the education and resources Dutch has to offer. Plus, registered providers gain access to the Mastering Functional Hormone Testing course, the Dutch Interpretive Guide, and one-on-one consultations with Dutch clinical educators. Plus, we have a brand new course that just came out, was just released. It's Introduction to Hormone Replacement Therapy. This dedicated support and education is designed to help you become the hormone expert. If you have any questions as we go, please submit them and we'll do our best to address them in a follow-up in the days ahead. So be sure to follow us across all social platforms to stay up to date. It's a pleasure to have you with us today, Dr. Smeaton. Take it away.
Thanks, Kelly. I'm really excited to be here and really to talk about a topic that's been really near and dear to our education team's hearts and certainly to our founder, Mark Newman. Menopausal hormone replacement therapy. Today, what I want to do is spend some time with you talking about the myths that exist around menopausal hormone replacement therapy, or MHRT or MHT, and really starting to help you separate fact from fiction. That's going to be the goal of today. So we're going to talk about a few of different myths. We're going to talk about the myth that MHT must be stopped at age 60. The myth that MHT causes or significantly increases the risk of breast cancer. The myth that it causes cardiovascular disease, dementia, and weight gain. So the point of today's webinar is really that you walk away feeling like you have the information and the truth that can help you better understand MHT and also help you explain to your patients why they might have heard some of these myths and what the truth really is. There are several acronyms in the presentation. This is just a little key for you. I'm sure you've probably seen most of these. Now, when it comes to menopause, many women experience symptoms that significantly affect their quality of life, and hormone therapy is FDA approved only for reducing bothersome hot flashes, moderate to severe hot flashes, vulvovaginal atrophy, and preventing osteoporosis. But many women find additional benefits along with just a general improved quality of life. But due to the heterogeneity among studies, there's a lot of misconceptions around MHT. And these myths and controversies often stem from challenges we have in interpreting studies. And that's going to be one big takeaway for today is when you look at studies, you really need to start to understand how to read them and how to make sure that when you see something in the media, some kind of headline, that you're able to take it and really understand what the research means. Today, we're going to clarify what the studies actually say about MHT. And one crucial point to understand is that menopausal hormone therapy should always, always, always be individualized for each patient. This means you're taking into account the patient's symptoms, their health history, maybe their family history, and the form and the route of administration, and also the dose of HRT that you're choosing for your patient. Now, I know this might sound complicated, but once the information's been presented, a really clear pattern emerges, and I think it's going to feel a lot more clear to you after today. So let's go ahead and dive in. Our first myth that we want to talk about is that MHT must be stopped at age 60. Now, when we look at where did this myth come from, probably it stems from the Women's Health Initiative, or the WHI, which was a study that looked at 68,000 women aged 50 to 79 who were either on menopausal hormone therapy or not on hormone therapy. This was published in, I think, 2003, and it really impacted the way we viewed hormone therapy for menopausal patients. Now, in this study, 2/3 of the hormone therapy participants started menopausal hormone therapy more than 10 years after menopause, and they were over the age of 60. Now, during the trial, what they saw was that there were increased risks of cardiovascular disease and breast cancer. And of course, that's concerning. And it was so concerning that they actually ended the trial early, and it got extensive media coverage. Now, when we've done further analysis and looked at the women in the study who were between the ages of 50 and 59 in less than 10 years since menopause when they started hormone therapy, we found the risks were very rare and the benefits were far more significant. In the women who were older than 59 or more than 10 years out from menopause when they initiated hormone therapy, there were fewer benefits and greater risks. So on the surface, the story seems really clear. MHT must be riskier for older women. And does that mean that we should stop it at a certain age? And actually, when I went through medical school, the training was lowest dose possible for the shortest duration of time possible, meaning get women off the hormones as soon as you could. But the truth is that while the previous statements about the WHI are true, they don't line up exactly with the myth that women must stop menopausal hormone therapy at age 60. Now, if we explain the WHI story with more detail, it looks a little bit different. In the women who were over 59 who initiated HRT for the first time since menopause, the benefits were not as strong as women who started at a younger age. Some have interpreted this to mean that you should stop at a certain age, but the Menopause Society and other associations really emphasize these two groups of women are different. Women who start over the age of 59 are very different than women who start closer to the cessation of menses and continue on hormone therapy past the age of 59. Two distinct differences there. One of the groups has a gap in time where they're exposed to hormone therapy. The other is more continuously on hormones, their own body's natural production of hormones, and then transitioning to a hormone replacement therapy. Starting early and staying on past the age of 59 is different than starting after the age of 59. So, benefit to risk ratio is less favorable when hormone therapy is initiated in a patient who's older, over age of 60, or has experienced those menopausal low estrogens without MHT for more than 10 years. And you can see the differences here. This comes from the North American Menopause Society, or now called the Menopause Society. You can see that when women initiate MHT younger, there's a really good benefit to risk ratio. It's safe and effective for most women. It showed a reduction in all-cause mortality, in coronary heart disease, and then there is a rare risk of stroke and venous thromboembolism when women are taking oral estrogens or conjugated equine estrogen, or we call it CEE. When women start later in life, there's fewer benefits and more risks. There was no effect at all on all-cause mortality or coronary heart disease. Risk didn't go up or down, but there was a greater risk of stroke and VTE when they're using oral estrogens. And I mentioned the oral estrogens because you're going to hear this over and over again. What we're finding is that the route of administration, whether estrogen is given orally or whether it's given transdermally, makes a difference, as well as we believe the bioidentical estradiol compared to conjugated equine estrogen, which is a synthetic estrogen. There was also this study recently published in 2024 that looked at menopausal hormone therapy beyond age 65 and its effects. This actually was done by looking at drug records, prescription drug records, and then healthcare visit records of 10 million senior Medicare women between 2007 and 2020 and doing a Cox regression analysis. What they found was that estrogen monotherapy, this is for all women over age 65, showed a risk reduction in mortality, breast cancer, lung cancer, colorectal cancer, congestive heart failure, venous thromboembolism, atrial fibrillation, heart attack, and dementia, and there were no risk increases noted. When they did estradiol plus a synthetic progestin, there were still some risk reductions, but we did see an increased risk of breast cancer. We'll talk more about breast cancer later on, but that was mitigated by using low-dose therapy compared to high, using a transdermal estradiol or a vaginal estradiol compared to oral. And then the third group used estradiol plus progesterone. This is the bioidentical progesterone versus medroxyprogesterone acetate, the synthetic. And here we saw a risk reduction in CHF, congestive heart failure, but an increased risk of breast cancer. So what are our conclusions? We see that lower risk was associated with a lower dose of estradiol, transdermal or vaginal estradiol compared to oral, and using bioidentical instead of CEE. So those are all things that you can apply to patients that are in a older age category. So what is the truth that we walk away from? The myth is that it must be stopped at age 60. That's not true. Menopausal hormone therapy really can be continued as long as necessary for symptom management, but the individual characteristics and prescriptions can help mitigate risk with age. So you want to review your patient's contraindications and risks, not only before you prescribe therapy, but annually. And then when you do follow-up visits, you should be looking at heart, cardiovascular risk factors, looking at breast cancer risk factors. Maybe that patient has a sister that was then diagnosed that would tell you a little bit more about their potential risk, although a sibling having breast cancer is not a contraindication for menopausal hormone therapy. But you want to be evaluating risk annually and consider changing the dose, changing the format, changing the route of administration. We do recommend still using the lowest dose necessary. Now, that doesn't mean to always use a low dose. You might be looking to get to a certain level for bone protection, not just hot flash mitigation, but the lowest dose necessary to achieve the benefits that that specific patient needs. And then also consider that transdermal E2 is safer than oral conjugated equine estrogen, especially as women age. So you want to make sure you're thinking about that transdermal approach. Now, the second myth that I want to talk about is MHT and breast cancer. Now, the myth is that MHT causes and significantly increases the risk of breast cancer. But the fact is that MHT only very, very rarely increases breast cancer risk, and that depends upon the formula and the length of time. We'll put that into perspective for you when it comes to how you can talk with your patients in a couple slides. Now, there were 2 hormone regimens given in the WHI study. The first was an estrogen-only group, and the second was estrogen plus progestin. So this was CEE or CEE combined with medroxyprogesterone acetate or MPA. The estrogen-only group showed a non-significant reduction in breast cancer cases. Estrogen plus progestin showed a rare increase. So what does that look like when we talk about rare increases here? The women in the estrogen-only therapy had 7 fewer cases of breast cancer per 10,000 users per year. That's non-significant. Women in the estrogen plus progestin had 9 additional breast cancer cases per 10,000 users per year. That is significant, but considered very rare still. Okay. Also, there was significant lower breast cancer mortality in the estrogen-only group, and there was no difference in breast cancer mortality in the combined group. Now, when we look at the combined findings of MHT and breast cancer risk, the transdermal E2 plus synthetic progestin had a slightly increased breast cancer risk, but when we used bioidentical progesterone, it did not, okay? And the estrogen-only therapy, bioidentical estrogens across several studies did not show an increase in risk compared to women who had never used estrogen. So bioidentical estrogens, again, appear to be a very safe choice. Breast cancer mortality is reported to be reduced in MHT users in many, but not all, observational studies. And the cause of that reduced mortality really can't be confirmed from these outcomes. It could be due to the fact that when women are on menopausal hormone therapy, they might be going through a more frequency of mammograms or getting earlier diagnosis. So they might be pursuing medical care more frequently. There could be multi-factors going on here that are unrelated to the prescription itself. Now, I want to talk a little bit about progestins and progestogens. Okay, so remember, progestogen is the umbrella term for all types of progesterone, right? Progestogens, things that bind to the progesterone receptor. We use the term progesterone to mean bioidentical progesterone, and then progestins are always synthetic. Okay, now different type of progestogens have different types of effect on breast health and breast cancer risk. Synthetic progestins like MPA might be associated with an elevated risk of developing breast cancer. However, bioidentical progesterone has been shown to not increase cell proliferation in breast tissue in postmenopausal women. There was a study called by Gompel in 2018 in Climacteric Journal. You can see the full citation below. If you want to look into this more, this is a really great study. Our team spent a lot of time really dissecting this study if you want to really understand what the true risk is with progesterone in breast cancer. There was also a really nice review, a systematic review by Stute that concluded that HRT or MHT that combines estrogens with progesterone, bioidentical, doesn't increase the risk of breast cancer in the first 5 years of use. After that, there is a slight increase, but still maybe not enough when you look at the benefit to risk ratio to decide for women to discontinue it. But when it comes down to it, women should really be counseled about the risk of breast cancer with HRT, putting the data into perspective. Now, there's a lot of other modifiable risk factors that have an even higher impact on breast cancer risk. Things like 2 daily alcoholic beverages, being obese, having a low level of physical activity. So if you're going to put women on MHT, you could also think about making some of these other lifestyle changes to really minimize any kind of ongoing risk of breast cancer. Also, regular breast cancer screening should be considered for all postmenopausal women, whether or not they're on HRT. So what's the truth here? The breast cancer risk, although this is obviously a very serious risk, is very rare. It's rarely increased with MHT, and it can be mitigated by using oral micronized progesterone instead of synthetic progestins and by getting regular breast cancer screening. Okay, the next myth I want to talk about is MHT and cardiovascular disease. Now, where is the origin of this? Some early MHT studies have found that some forms of hormone and some regimens of MHT can cause changes that negatively impact the cardiovascular system. These studies found those negative impacts with oral estrogens like CEE, with oral progestins, like those are the synthetic progestogens, like MPA or medroxyprogesterone acetate, and when women initiate MHT after the age of 59 or more than 10 years after the cessation of menses. This is what we talked about in the first myth. But what we see is that E2 therapy, estradiol therapy, has actually been found to support a healthy cardiovascular system because it helps to maintain vascular elasticity and endothelial function, which is a really amazing area of cardiovascular research more recently, that the health of the endothelium is critically important for preventing cardiovascular disease. So you want to consider the health of the patient when they start MHT and all of their individual risk factors. But MHT has been found to be safe with rare cardiovascular disease risks, especially when it's started in women under the age of 59 or less than 10 years from the onset of menopause. So keep in mind, cardiovascular system is dynamic and complex, and it interacts with every other system in the body. And so the impact of MHT on cardiovascular disease is also multifactorial. It includes the health of the patient at the time of MHT initiation and the route of administration and the form of the progestogen and the estrogen. You're going to hear me say this over and over again. It's not surprising. The form, the dose, the route matter. When women are over the age of 59 or more than 10 years post-menopause, they are also more likely to have worse baseline cardiovascular health than when women start in their younger ages, about 50. This might be why when women start later, they have more increased risk of DVT, stroke, and cardiovascular disease. So it could be that the baseline status changes between 59 and 69, or 50 and 59 are different. Women who initiate MHT within 10 years of menopause actually have improved long-term cardiovascular outcomes. Now, another thought is that oral estrogen and oral progestin therapy goes through extensive first pass metabolism in the liver. So, when you take an oral estrogen, for example, about 95% of it is caught by the liver and eliminated before it enters the bloodstream. This is one of our body's beautiful protective mechanisms to protect us from eating things that could be harmful. But this increases liver clotting factor synthesis. And increased clotting factors are a root cause of stroke and VTE. So it's thought that the increased VTE and stroke risk could be linked to that oral use, oral estrogens, oral progestins. Now, with most patients, the benefits of MHT for cardiovascular disease outweigh the risks. However, best practice dictates that you want to assess cardiovascular health when you're screening for both initiating and then again, ongoing continuation of MHT. You want to start MHT within 10 years of menopause if possible. And if you're starting later, just proceed with extra caution. Make sure your patient is in a good state to start MHT. And lastly, use a transdermal form of estradiol with oral micronized progesterone for the safest long-term cardiovascular outcomes. So, transdermal estrogen has not demonstrated increased VTE and stroke risk, probably because it bypasses liver metabolism, although it's not been as thoroughly studied as oral estrogen, so you've got to keep that in mind. And caution is advised with patients who have a high stroke or a VTE risk for all estrogen therapy, but transdermal estrogens are a safer approach. And also, oral micronized progesterone does not cause that increased synthesis of liver clotting factors in the available studies, and it's not demonstrated a risk for VTE and stroke. That's why we want to be using those forms. Okay, so let's move on to our fourth myth, which is around MHT and dementia. Now, where does the origin of this myth? Dementia is this chronic degenerative disease of the brain, and we've also seen that dementia increases sharply for women as they go through menopause. This fact put estrogen replacement on the radar to see whether it could really help with dementia prevention. But several older large studies found increased dementia risk. So let's start to break that down. What are the factors that might cause different outcomes in dementia studies? The first is the timing with menopause. This is similar to cardiovascular disease, and we call it the critical window hypothesis. There is a theoretical critical window in which supporting estrogen levels could prevent brain decline. We'll talk more about that. The age of onset of menopause. When you start menopause earlier, it actually increases dementia risk due to lower overall estrogen exposure for a woman's lifetime. The older formulations of MHT also have a negative impact, where newer formulations seem to be more neutral or beneficial. And then similarly, the dosing and the regimen make a difference. Lower dose E2 and intermittent or sequential progestogens can be ideal. And then lastly, you do have to consider other health conditions that increase dementia risk, and that might mimic menopause symptoms. Some women, for example, might seek out hormone therapy in part due to a decline in brain health. So let's talk about that critical window hypothesis. When we look at observational studies, what we see is starting hormone therapy earlier in the menopause process shows better dementia outcomes. Okay. The proposed mechanism is that you're really preserving premenopausal brain health by maintaining higher estrogen levels. Once the brain has experienced prolonged times with lower hormones and then a subsequent brain health decline, it might not be able to recover. So think about the changes when you're exposing cells, in this case brain cells, but really all tissue. They're constantly exposed to estrogens, right? Once the estrogen is gone or declined with a natural menopause, cells adapt and they adjust to that. And receptor function might change, for example. Cellular functions adapt because they're no longer being stimulated in that way. When you then dump estrogen back into the system, the response to estrogen might not look the same as it did before that decline and before that change. This is where that critical window hypothesis comes in. So older formulations of MHT, like oral CEEs and synthetic progestins, this is what was used in WHI, might be associated with a higher risk of dementia. Now, the newer transdermal E2 with oral progesterone are associated with a reduced risk of dementia. And again, oral estrogens and synthetic progestins increase liver clotting factor synthesis, which, in addition to cardiovascular risks we talked about before, can impair vascular perfusion in the brain and might also affect cognitive function. Now, we know that higher MHT doses are associated with increased dementia risk, and lower doses are associated with reduced dementia risk. So that does beg the question, though, if estrogen is good for the brain, wouldn't a higher dose be better? Doesn't really show that in research. Now, higher doses of MHT might be that those are really used only in women who have persistent symptoms, which again, persistent symptoms of menopause might indicate a poorer underlying health. And that could be an increased contributor to dementia risk rather than the MHT itself. Remember, association doesn't always mean a cause and effect. Early signs of dementia also have significant overlap with menopausal symptoms like hot flashes and mood swings and poor sleep. So we have to consider again, is it the MHT or is it the patients who need a higher dose of MHT that have a higher risk? Now, progesterone we use in MHT because it protects the endometrium. And part of the way it does this is it reduces estrogen receptor density and it limits estrogen receptor activity when progesterone's around. But progesterone could also reduce the benefit of estrogen with all of these different functionality because it could have the same effect to reduce estrogen receptor density and estrogen receptor activity in the brain when they're taken continuously. So it's interesting because studies that show a cycling progesterone instead of a continuous progesterone regimen, that would be 12 to 14 days on and then off of progestogens, that cycling actually has better outcomes compared to the continuous combined MHT regimens. So that's another consideration. So what's associated with an increased incidence of dementia versus a reduced incidence? Increased incidence of dementia is associated with starting MHT more than 5 years after menopause, lower lifetime estrogen exposure. So this could be a late menarche, early menopause, or being nulliparous, oral estrogens, oral progestins, high dose E2 in menopause, and a combined continuous MHT. Now, if you really want to try to reduce the risk of dementia, you want to follow what the data says there. Start MHT less than 5 years post-menopause. Look at women who have a higher lifetime estrogen exposure, early menarche, late menopause, or having one or more pregnancies, using transdermal estradiol, oral progesterone, and a lower dose of E2 in menopause. And then again, using a cycling MHT instead of a continuous use of progesterone each month. So just in closing, when we look at MHT and dementia, the current state of research is really not adequate to fully address the effect of hormone therapy on dementia risk. So I want you to know that because sometimes when I give presentations, I say, science is always evolving. And part of what I said I'm going to say today is going to be proven wrong. I just don't know which part, right? This dementia risk area is one where really the jury is not out. We don't have large enough studies, controlled studies to get the best information. But what it looks like, where it looks like it's headed, is that MHT might have a role in reducing the risk of developing dementia. Again, you want to initiate MHT close to the onset of menopause, less than 5 years if possible. Use the newer preferred forms of transdermal estradiol and oral micronized progesterone. Consider cycling the OMP 10 to 12 days per month and use the lowest effective dose. I do want to point out also, research doesn't support using MHT as an Alzheimer's or dementia treatment. So really this is for prevention, or I would say it to maintain your cognitive health versus to try to treat a pre-existing dementia. Okay, the last myth that I want to cover here is a myth around MHT and weight gain. Now, where does this come from, that the thought that MHT causes weight gain? Probably it stems from the fact that many women experience weight gain around the time of menopause without any noticeable lifestyle changes. I hear so many women share this, and in my practice, I remember hearing this, that women would complain that they're gaining weight even though they've not changed their nutrition or their exercise routine. Some women might attribute that to the new hormones that they're taking. But the truth is that the weight gain that we see in menopause on MHT is likely more due to aging, a decline in physical activity, a decline in muscle mass, and low estrogen. In fact, what we see is that estrogen therapy has a beneficial impact on many metabolic parameters, including insulin sensitivity, maintenance of muscle mass, normalizing cortisol levels, and the metabolic rate. Some women also, when they're on progesterone, will retain some water, and that could be another reason why they feel like they have weight gain. That could be mitigated if that's a real problem by switching from oral to vaginal progesterone or by changing lifestyle habits to reduce water retention, like salt reduction as an example. Like I'd mentioned, hormone changes, especially low estrogen, can contribute to a lot of things: increased fat mass, reduced muscle mass, changing fat distribution from that traditional estrogen related pear shape to more of an apple shape, where we see more weight around the belly, around the middle, which is more associated with insulin dysregulation. Reduced insulin sensitivity, increased cortisol, increased inflammation, leptin insensitivity, so our hunger signaling is off, and also fatigue. And all of these are associated with low estrogen, and all of them can contribute to that midlife weight gain. Now, there is significant evidence that estrogen therapy can actually reduce the weight gain that women typically see in midlife, but MHT might still coincide with midlife weight gain. Compared to women who don't use MHT, the MHT users in the WHI actually preserved their lean body mass better and had an upper to lower body fat mass ratio. This means that that pear shape that I just talked about was maintained rather than transitioning to more of that metabolically unhealthy apple shape. Now, there was a small study published in 2003 that compared oral CEEs to a transdermal E2 patch. What they found was that the estradiol patch helped to increase lean body mass, with a decrease actually in lean body mass on oral CEEs. The estradiol patch did not change total body fat mass, although that did increase on oral CEEs. There was an increase in bone mineral density with the patch, but no change in bone mineral density on the CEEs. And there was actually an increase in lipid oxidation on the patch, a decrease in lipid oxidation on CEEs. Now, this is a small study. It should be taken with a degree of skepticism, but what we see here is that transdermal E2 outcomes were preferable to the use of oral estrogens. So there's also been many other studies using different formulations of MHT which have found benefits. Some of those benefits include a reduced waist circumference, a reduced waist to hip ratio, increased metabolic rate, increased insulin sensitivity, and actually women had a reduced caloric intake when they were on hormone therapy and an increased energy expenditure. So all of these metabolic changes and morphological changes are associated with better outcomes with weight and with metabolic health. So what is the truth around this myth? Weight gain occurring around menopause could be slowed or even stopped by using MHT. It's very beneficial for weight. Some of the key points to take home: estrogen loss at menopause actually promotes weight gain through many different physiologic changes, and estrogen replacement can mitigate the effects of estrogen loss, but might not do so completely. We also know behavioral changes with aging are also at play, things like reduced physical activity or increased caloric intake. So make sure that you're counseling women to maintain a healthy lifestyle through this transition. But we know MHT, along with those lifestyle changes, can help prevent weight gain and possibly even help with weight loss after menopause. So what are some of our consistent insights from these myths that we've talked about? 1, these myths often stem from older research, primarily the WHI study, which used oral conjugated equine estrogen and synthetic progestogens. But still, older research found in most cases the benefit of MHT outweighed the risk, especially when you look at the population of women who are most likely to pursue MHT. It's not women over 60, more than 10 years out from menopause. It's women in perimenopause and early menopause, right in that early side of that transition. However, bioidentical transdermal estradiol and oral micronized progesterone stand out thus far as really showing improved outcomes and reduced risks in many, many health areas. So from our point of view, you should always be thinking about using these forms of hormones. And we can always optimize the benefit to risk ratio when we individualize treatment decisions to the health of the patient, we use the lowest effective dose, and we also holistically reassess that patient every single year. It's not a one and done visit. You don't put women on hormones and never see them again. You should be constantly reevaluating whether that's the right formula, dose, etc. for the patient. But ultimately, understanding the origins of these myths and the small truths that are inside the myths can help you and help your patients understand how to make the right choices around hormone therapy. So I do want to wrap up by just summarizing the things that we've talked about. Myth number 1, MHT must be stopped at age 60. What's the truth? There is no specific age that MHT must be stopped. There are some concerns with age, but these are really due to the baseline health of the patient. And initiating MHT when women are over 59 or more than 10 years out from menopause shows fewer benefits and more risks. That doesn't mean you would never prescribe them. It just means you have to individualize the care and measure and monitor to make sure you're making the right decision for that patient. Staying on MHT that was started less than 59 years of age or less than 10 years after menopause is safe, as long as MHT is still safe for the individual patient. Lastly, transdermal E2 might be your best choice in older women compared to oral CEEs or an oral E2. And lastly, your patient risk should be assessed every year to make sure you're optimizing the benefit to risk ratio. Okay, our second myth, MHT causes and significantly increases the risk of breast cancer. Remember, the truth here is MHT is safe and effective for most women. There is an increased breast cancer risk, and it's obviously a serious risk, but it's very rare, and it can be mitigated by regular screening. When I say it's very rare, that's not my own personal opinion. That's the Menopause Society's reported opinion. And again, that increase was 9 cases in 10,000 women users per year. And again, you have to put it into perspective with other things that increase breast cancer risk, like drinking alcohol, being overweight, or low physical activity. Now, estrogen-only therapy is associated with a reduction in breast cancer risk, and bioidentical progesterone is not associated with increased breast cancer risk in the first 5 years. Many older studies used synthetic progestogens or synthetic progestins, which were associated with a rare increased risk, but no increase in breast cancer mortality. Our third myth, MHT causes cardiovascular disease. Now, the truth is that E2 therapy has actually been found to support a healthy cardiovascular system by maintaining vascular elasticity and endothelial function. E2 therapy is best when it's used transdermally. So again, the benefits are best with transdermal estradiol. Oral estrogens and oral progestins can increase liver clotting factor synthesis, which is associated with increased VTE risk and stroke risk. Now, there are ways to mitigate these risks. Use the preferred transdermal E2 in oral progesterone forms. Screen for risk in all patients who want to start hormone therapy. And patients who are over the age of 59 or over 10 years from the start of menopause should avoid oral estrogens. Our fourth myth, MHT causes dementia. Now, the truth is estrogen has a beneficial impact on the brain. The increased risk of dementia associated with MHT is likely linked to oral estrogens and progestins, which can increase dementia through increasing liver clotting factor synthesis and anti-estrogen effects. Some steps to optimize MHT for dementia include to start MHT close to the onset of menopause, again, less than 5 years when it comes to menopause, when it comes to dementia. Use the newer preferred forms of transdermal E2 and OMP, and consider cycling the OMP 10 to 12 days per month rather than doing a continuous progesterone. And lastly, use the lowest effective dose of estrogen. In our last myth around MHT causing weight gain, the truth is that MHT actually mitigates weight gain and mitigates some of the negative metabolic changes that happen with menopause and aging. Make sure you're addressing lifestyle factors because MHT doesn't prevent all age-associated weight gain. I will leave you with our references here. You'll have these in your copy of the slide. And otherwise, I just want to thank you for your attention today, and thanks for having me, Dutch team.
Thank you for joining us for this insightful webinar with Dr. Jaclyn Smeaton. We hope you learned something useful. And watch your inboxes tomorrow for a link to the recording and to access the resources we shared today. You can learn more about the research behind the Dutch test at dutchtest.com/research, and make sure to visit the Become a Provider tab at dutchtest.com to register for an account so you can gain access to even more hormone education and research. Be sure to follow at Dutch Test and subscribe wherever you get your socials to stay in the loop for upcoming webinars and podcasts. And don't forget to sign up for our brand new Dutch course, Introduction to HRT.